The following podcast is part of a certified educational activity titled Unifying Surgical-Oncology Expertise in Resectable Gastric and Gastroesophageal Junction Malignancies, leveraging the evidence on perioperative immunotherapy platforms to deliver personalized care. Access the entire activity and complete the post-test at peerview.com/YYF860. Downloadable slides and practice aids are also available.
Good evening, everyone. Thank you for joining us. Today, Dr. Ginjalian and I will be talking about unifying surgical oncology expertise in the treatment of resectable gastric and GE junction tumors. We're going to be discussing the role of perioperative immunotherapy to drive personalized care. Our goals today will be to discuss the evidence for the evolving use of immunotherapy around the perioperative setting for resectable gastric and GE junction tumors. We'll be discussing how we as a team personalize care, as well as other team-based strategies to make sure that our patients get the best perioperative care for resectable GE junction and gastric cancers. First, to start off, I will set the stage for how we have been approaching surgical care of gastric and GE junction cancers. As we all know, the incidence of these cancers is growing, and currently we're on track to have over 1.2 million cases per year of people dying from gastric and esophageal cancers. I train and work at a tertiary cancer referral center, so most patients already have a diagnosis when they come meet me in the office, and they already come to me with some of these perceptions of gastric and GE junction tumors. One, they think it's very poor prognosis. Two, they've heard about the chemotherapy, and they heard that the chemotherapy regimen is very tough to swallow. And actually, most of them have not heard about the use of immunotherapy for this disease. We'll address each of those separately. So the perception that this is a high price to pay for a small benefit is pervasive. And there is some fact to this. If you look at the graph to your left, this is the survival by stage after esophagectomy. And for example, for stage 3 disease, the survival is less than 20%. And for esophagectomy, the mortality as measured by in-hospital death rate is still quite high at about 8 to 10%. For gastric cancer, there's slight improvement. So this is in the last 20 years. As you can see, there's slow improvement in the 90-day mortality from 13 to 8%. And a lot of this is mitigated by increasing surgical volume, as well as our techniques to rescue patients. This is with the help of a team. So advanced interventional radiologists, they can help us by helping draining abscesses in difficult places. Sometimes they can help us gain enteral access. And you also need a very good advanced GI team. They help you stent across leaks. In our center, we use a lot of endovacs to seal leaks. And again, enteral access is key. Many of this benefit in mortality is also from prehabilitation. So this takes an entire team to really make sure that patients are optimized for surgery before surgery. This includes nutrition. So all of our patients see a nutritionist essentially on the day of their diagnosis to help them prepare for what it will be like to live without their stomach or live without their esophagus. They also are trained from the time they're on chemo to keep up their weight, as that's an important marker of both their functional fitness as well as how they're going to do after surgery. And we have made incremental progress in this disease, and most of it is due to perioperative therapy, which we'll be discussing next. As you can see, stage by stage, over the last 20 years, we have made some small gains. So one of the questions that we have is, what is the optimal perioperative therapy? What is a combination of chemotherapy agents we should use? Should we use radiation? What is the role of immunotherapy? And we're not going to discuss this today, but there's also a question of whether we should be incorporating targeted therapy earlier in our treatment. So as most people in this audience know, FLOT is at the backbone of treatment for gastric and gastroesophageal cancer. This was the FLOT4 trial, which showed the superiority of FLOT over the MAGIC regimen, or ECF. This was statistically significant. And I will also like to point out the chemotherapy completion rate. It's very high in both groups for preoperative chemotherapy, and even postoperative chemotherapy, the completion rate of FLOT is actually superior to the MAGIC regimen. The rates of curative resection and R0 resection are also similar. The next question is, well, do we need radiation? As many of you know, the rationale for radiation comes from the CROSS trial, which compared chemo-RT to surgery alone, and there was a benefit, though a lot of this benefit was driven by the group that has squamous cell histology. When you looked at only adeno group, there is a small benefit, and many of the subsequent trials really sought to answer, in the adenocarcinoma group, is there still a benefit? So the first trial to look at that question is the neoadjuvant trial, which compared the MAGIC regimen to CROSS. Unfortunately, this occurred during the time of COVID. There were accrual issues, and also during the same time period, the standard of care switched from MAGIC regimen to the FLOT regimen. So actually 15% of the patients on this trial received FLOT. And as you can see, obviously, from those curves, there is no difference. And what really answered this question about radiation compared to FLOT was the SPOPE trial, which again showed that FLOT was superior to the CROSS regimen. This was statistically significant, and there's a difference both in the median overall survival rate of 66% in the FLOT group versus 37 months in the CROSS group. What accounted for this difference? Well, it's really in the rate of distant recurrences, because ultimately that's what patients die from. So as you can see on your right-hand side, the rate of distant metastasis in the FLOT group was 31% versus 47% in the CROSS group. So the 3-year distant metastasis disease-free rate was much higher in the FLOT group versus the CROSS group, and that's what ultimately determines the prognosis. And really what hit the nail on the coffin for radiation, especially also for gastric cancer, was the Top Gear trial. So this looked at perioperative chemotherapy alone versus perioperative chemotherapy with the use of radiation. And again, as you can see by the graph on the left, there is no difference at all. And if you looked at the NCCN guidelines in 2024, there was still a question, and you can still consider radiation. And here now in 2026, it's been taken entirely out of the NCCN guidelines. So there is still this conception that FLOT is a toxic regimen. There's no doubt that there are higher toxicities with FLOT compared to the CROSS regimen. But there is still quite a high completion rate. So in the SPEC trial and intention to treat analysis, 71% of patients completed the regimen of FLOT. And if you looked at preoperative chemotherapy, that rate is higher, actually at 90% versus 92% completed CROSS. And we think that there's still a strong presence of radiation oncologists in the local community who still think that there's a role for radiation, even though there is strong evidence that FLOT really is a superior regimen. And here we come to immunotherapy, and that has really changed our perioperative thoughts. So the story of immunotherapy started with adjuvant therapy with the CheckMate 577 trial, which showed that in patients, the addition of nivolumab to patients with incomplete path response had a reduction in disease-free survival. Improvement in disease-free survival, and that led to the approval of nivolumab in this setting. And in the perioperative setting, atezolizumab was introduced to the FLOT regimen with the Dante trial, and that showed an increased path response rate. And the next two trials really tried to answer the question whether or not that increased path response rates actually translated to increased event-free survival, which includes recurrence as well as survival. And the Keynote 585 asked that with the combination of Pembro, and most recently, the Matterhorn trial asked that with the combination of durvalumab. And as you can see with the durvalumab trial, which Dr. Gingeling will talk about later, there is a significant difference with the addition of durva. And so the question is, we all know that immunotherapy has an effect, and immunotherapy actually in the community setting is widely used for other cancers. So why is the acceptance rate for perioperative therapy in gastric cancer much lower? Well, part of it may be that until recently, the standard of care is still very much chemoradiation for example, GE junction tumors. And the thought was you used immunotherapy only when there's residual disease. And the oncologists may not be aware about the benefits of neoadjuvant immunotherapy, but it is actually in the NCCN guidelines. And really, it takes a team of surgical oncologists, medical oncologists who are really managing a lot of the toxicities from FLOT, radiation oncologists, again, the gastroenterologists and the nurses, and also what's mentioned in the others, pathologists, nutritionists, and everyone else to get our patients through this regimen.
All right. Thanks for the a great. You know so much about this systemic therapy that I feel like we can really focus on immunotherapy now. And of course, if you ever have a Matterhorn question, this is the time to ask. So don't be shy. This is, I'm the PI for the study. So any problems with it you have or feedback, I would love to hear, because we're designing the next phase of these therapies to continue to improve on what we now know, that empiric therapy no longer is good enough for this disease. And I do realize that, of course, in the community and even in university-based practices, gastric cancer is often a disease that is being sort of cared for, but by non-acute specialists. But that being said, I think there's plenty of data now that we need to biomarker test these patients. And if you have, for example, an MSI patient or HER2 patient, even in perioperative setting, this matters. So what it means for you is that just introduce the idea to the patient as you're talking to them about the biomarker testing, and all of the patients are really keen on surviving this cancer. So no one's ever going to fault you for getting additional tissue for biomarker testing. But the 4 biomarkers that are prime time now for this disease are PD-L1, HER2, MSI, and Claudin. And I think MSI is probably the most important in terms of outcomes in perioperative setting, where if you have an older person that you really don't want to give, perioperative therapy, and if they have MSI tumor and it's a distal gastrectomy, I think that's one of the areas where, it's justifiable, because more than 85%, 90% of MSI tumors you could cure with surgery alone. So if it's an elderly patient, with an easy operation, I think I would say that's fine. But what we also know is that, CPS, for example, is not a very reliable biomarker. And I think there's important to note that actually in the Matterhorn study, we didn't even use CPS, combined positivity score. We used a tumor area positivity, TAP. And essentially, they're very similar. And in the head-to-head comparison in several metastatic cohorts, but also in our Matterhorn cohort, they essentially have a nearly high 100% concordance. In other words, if something is CPS1, it's also TAP positive. In fact, TAP is probably an easier way to assess it, because instead of actually having to count all the cancer cells, all the stroma, and the positivity rate as is calculated by CPS, it's a formula. TAP, it's more of a gestalt. Is it positive or negative? So it's almost impossible really to be TAP negative. So if you have a pathologist that is reading a tumor as PD-L1 negative, we just had a case in a clinic this week. Turns out there was not enough sample in one case. It was not enough stroma for them to call it PD-L1 positive. And in another case, it was a typo. So if you see a PD-L1 negative case, have your PA or a fellow, or even you, if you know the pathologist, call them and say, like, can you look at this again? Because it's important, because some of the guidelines, as you will hear, and we had a great question already, is restricting, especially the metastatic disease, using immune checkpoint blockade. So as Dr. Liu nicely summarized, 577 is the first data and was the only sort of saving grace for the radiation oncologists, because even when we initially presented, all the Top Gear and SOPEC studies that essentially showed that radiation does not improve survival. And if you need to operate on someone and you think the only way you can get an R0 resection with radiation, you shouldn't be operating on these people because they have metastatic disease. They die of metastatic disease. And, it's not very satisfying to take someone through a 6-hour operation for them to die 3 months later or 6 months later without ever getting any additional therapy. So what 577 data did show is that you can impact micrometastatic disease or delay recurrence with adjuvant nivolumab in high-risk patients, people with node-positive disease. We know those are essentially walking M1 disease cases. But the OS benefit is only restricted in PD-L1 positive patients, and even then, it's relatively modest. Hazard ratio is 0.85. That's with a caveat because, obviously immunotherapy is used in stage 4 disease. So adjuvant immunotherapy, it's, delaying disease recurrence, or you could give it to them later, right? The survival benefit is plus minus. So why is it so important to kind of pause, take a deep breath, and not operate on the patient? Send them to us first. Data across all cancers, solid tumor, no matter what you look, breast, preclinical, clinical, melanoma, kidney cancer, it shows that while the tumor is still in place, it's a critical time to educate the patient's immune system so they can fight the cancer later after you take it out. It's, I don't know if any one of you have a dog, you have to let it smell the thing you're looking for, right? So it's the same analogy. In fact, Matterhorn is the first definitive evidence of that, and you have now proof there's an OS benefit. So why would you want to operate on a case where you know that in adjuvant setting, the immune response is not going to be as deep or as durable? And it's interesting, we're presenting some data at AACR that actually shows that giving you adjuvant versus adjuvant, the change of the immune response is really drastic. But also, the patient is not even going to tolerate all the adjuvant therapy as well, right? We know that from all the studies. So the proposed rationale of why neoadjuvant immunotherapy is better, as at the very bottom, you see there's more colorful circles. That's the anti-tumor response, right? That's what you want. And when the patients come and tell you, it's very helpful for you to start that discussion, for them to visualize the cancer, because the reality is many of these patients will, have care elsewhere, and often they show up in my office asking for help when it's already too late. They're not eating. They just had some commando operation with T4 and 3 tumor, and then they're, coming to be cured. It's too late. So what did the Matterhorn do? The one important thing it did, the first important thing, it unified approaches, East, West, South America, North America, Europe. Everybody agreed to give it FLOT. And even doctors in South Korea, Japan, Taiwan, where historically, it's a surgical disease, people agreed to, and we accrued ahead of schedule during the global pandemic. What we also showed that is FLOT feasible as a global approach. So these are not all, Upper East Side patients that are being cared in my practice. They're being treated all over the world. And it's a Western, but also Eastern approach. And we also looked at G junctions. We looked at gastric cancer. We looked at patients irrespective of PD-L1 status, right? So, and it was close to 1,000 patients. So not a small study. Things that we could have done better. But realistically, I don't think in my lifetime, and maybe you can tell me during the discussion if feasible, we didn't mandate laparoscopies because most centers don't always do it. And again, maybe a third of the patients or so had laparoscopy. So as you're looking at subgroup analyses of these studies, that's what you have to keep in mind. We didn't mandate central histology confirmation, like if it's diffuse versus intestinal, because a lot of centers don't do that. We wanted to do a realistic study, and we didn't mandate EOSs. I think EOSs are not that helpful to begin with, because if you see the tumor on the CT scan and the patient can't swallow, what is the EOS going to add, right? You know it's not a T1A tumor. But nonetheless, this was a very well-balanced, well-designed study. We predominantly, of course, saw gastric as expected, but now even in the East, the breakdown is shifting. We're seeing G-junction adenocarcinoma even in Asia. And MSI was very rare. So in, all-comer population, MSI is very rare. And we saw event-free survival, right? So you see the plateau, and the Matterhorn supports the global adoption of perioperative durvalumab with FLAD. This was, the ASCO plenary, the New England Journal of Medicine, et cetera. Big deal. But what we also see is that, even in older patients greater than 65, there's a benefit. This is the forest plot. So anything to this side is good, or I guess, yeah, that side, good. PD-L1, even PD-L1 low tumors, PD-L1 negative patients benefited. And it's very rare population. So of course the hazard ratio is going to be wide, or the confidence interval. So this was the game changer, right? OS is better. So this is in the era of metastatic treatment with immunotherapy, where I give it like water. Giving it early, there is a survival benefit, unlike 577 where there wasn't. In fact, median OS is not reached, even with long follow-up. Hazard ratio is 0.78. We've not seen anything like this in this disease, where there's no targeted therapy approved in perioperative setting. There's a higher rate of complete response rate, 19%. And the best news is that long-term follow-up, in this paper we submitted to Lancet, long-term follow-up shows that if you are one of the patients who have a complete response or near complete response, so major pathologic response, you don't recur. And that's really exactly the reason why you need to treat the patients while the tumor is still in place, because first of all, we will already know, a week after the operation, where they fall on this continuum of survival. But also we are able then to do something for people who are non-responders, right? Not right now, because that's probably the most common questions I get asked. Will you switch to something? Doesn't work that way. But in the future, right? And so the FDA approved this regimen irrespective of PD-L1 status. EMA is approving it irrespective of PD-L1 status. People ask me all the time, what about NCCN? The NCCN CPS1 designation was done before the OS benefit. They haven't amended it. I think, we all know that it's opinions of people. So they're working on amending it. But my point is, most of the time we're able to get a durvalumab approved, with a phone call if needed. But we have not had any issues. So the R0 resection rate was quite good. I mean, we could do better probably. In the R1s, most of them were people who were not laparoscoped. They went in and they saw, they tried to take it, and then there was a radial margin or something like that. But I think it speaks to volumes to the fact that we're getting more sophisticated treating these patients, because these were not all tertiary cancer centers, obviously. And what's excellent to see is that most patients were able to complete all perioperative FLAD, right, almost 100%. And even adjuvantly, the rate of completion is 2/3, which is better than even the data that Marian showed. And people also say, well, it's a year of durva, it's so much. 52% of patients completed all durva, because durva is only once a month. They just come from, from all over and get it. So what about the adverse events? Not surprising, all the adverse events are FLAD related. So durva actually doesn't add that much, right? We see some immune related things that we can talk about, but The good news is it didn't compromise the likelihood of complete resection, didn't compromise completion of surgery. And again, most of the side effects, as you see here, because if you look at the flat column, 59%, for example, versus Duraflot, 60%, it's almost identical. So if your oncologist learns how to give flat, and I'm happy to teach them, they'll be able to get the patient safely through, right? One thing important to note is that you don't have to give full doses. If the patient has toxicity, dose reduce. Sounds like common sense, but you'd be surprised that some people have just a little bit of a hesitancy to do it. Diarrhea, nausea, neutropenia, alopecia, all of those things, and neuropathy are caused by flat. And we often, drop some components of it in adjuvant setting. That's okay. The update from the ASCO GI, as I mentioned, there were no worsening and adverse events, not significantly at least. And this is very important. So patients who completed all cycles of flat and discontinuation data. So you can look through it, but essentially, event-free survival was improved with Duro and flat versus placebo of flat, regardless of flat completion. So that's important. Just start, right? Try to give them. You probably don't need to give them even all cycles of perioperative flat. Just getting the immune system going with a triplet plus immunotherapy with durvalumab is very helpful. Okay, so some of the aspects, basically you're you're opening the Pandora's box. So all of the immune-related adverse events theoretically could occur. Most common adverse events are endocrinopathies, so thyroiditis. So you have to monitor them we monitor them TSH3 to 4. Some patients get pancreatitis and diabetes, very rare, but it does occur. Acute interstitial nephritis, very rare, also could occur. That's probably less than 7%. And I think one of the, real worrisome side effect that oncologists and surgeons have a hard time to knowing which one is it chemo, is it immunotherapy, is asymptomatic increase in transaminitis. So ACLT bumps, Billy is normal. And usually, if it's only grade 1 or 2, so it's like in the hundreds, you can hold the drug, have them get repeat labs in 2 days, and it becomes very clear what it is. Because immune-related adverse events do not disappear or improve after 2 days. Chemo things fluctuate, right? So if the AST went down a little bit, it's not immune-related, and that's kind of the litmus test that we use. So I think the management typically, it's never wrong to take a break and wait, especially if it's a grade 2. If it's grade 1, sometimes you can treat through, especially if it's mild stuff. They get all, a little itchy rash or joint problems, not a problem. But of course, for grade 3 or 4, hopefully, those were very rare, very rare. If they're noticed early, intervened on, there's really no deaths related to the outcome, and there was no delay of surgery. The rate of onset is variable, but most of the time it happens within the first 2 months. So you should know kind of this, this is kind of data from melanoma, but in our experience, colitis is extremely rare. You don't see it with anti-PD-1. This is more of a CTLA-4 toxicity, but all of the other side effects kind of occur within the first 2 months. So you would know by the time, they're coming to you. Neutropenia, we dose reduce, we give them Neulasta, Neupogen, things like that. So if you're seeing a patient with white count of 20, they probably got Neupogen. They're not septic. So just ask your oncologist before you panic. But fatigue and GI side effects, they all get nausea medicines. One of the biggest advancement in GI tumors has been really managing of nausea. So the nausea management is quite good, and that's why we can get patients through flat better. Okay.
So I'm going to discuss the surgical journey that these Matterhorn participants went on. So to start off, Obviously, these patients who did receive durva had no delay in surgery or time to adjuvant treatment. In fact, the number of patients who attempted surgery and completed surgery were exactly the same. The number, as we mentioned before, having R0 resections, completely the same. Type lymphadenectomy, completely the same. And then also receipt of adjuvant therapy, very similar in both arms. There was also no surgical complication differences between the two groups. I don't know if any of you have operated on patients after they've gone immunotherapy. You'll notice that the planes are a little bit stickier, the lymph nodes are a little bit harder. But from the Matterhorn data, we see that there's no increase in anastomotic leaks or any other complications related to the surgery itself. In fact, surgical mortality is exactly the same between the two groups as well. And if we look at the benefit from adding durvalumab, this was irrespective of where the tumor was, your resection margin, as well as the extent of your lymphadenectomy. So the top panel there is comparing gastric cancer versus GE junction tumors. Again, durvalumab had a benefit in both groups. When you looked at the extent of lymphadenectomy, even a D1 lymphadenectomy, which is still practiced in some places, there was still a benefit with durvalumab. Obviously, the curves shift up a little bit where D2, D3 lymph node resection. And then if you look to the right panel in terms of R0 resection and R1 and R2, even in the R1, R2 groups where you think the biology must be poor, there was still a benefit with adding durvalumab. And obviously, the addition of immunotherapy in the perioperative setting is still being studied. These are two trials that are ongoing. We should have the EFS data soon from the Dante trial of adding atezolizumab to FLOT. We already know from interval analysis that there's improvement in pathologic response, similar to the other trials. And then there's also an ongoing GEMINI-PeriOp trial in gastric cancer, looking at several targeted agents as well. Okay, so we're going to go through some cases together.
Right. So this is a G junction patient, 66-year-old woman who's relatively healthy. She has some mild Hashimoto's, but presented with a T2N1 G junction tumor. Showed mild SUV of 5.6. I would say in patients like that, PET scans are probably not that helpful if the SUV is so mild. Uptake in terms of like if it, reduces with treatment, it's not that reassuring because it's low to begin with. But like a patient like this, I would get a high resolution CT scan also to make sure we're not missing anything. But she had no evidence of distant metastasis. And on biomarker testing, HER2 negative, PD-L1 negative, MMR proficient. So for a patient like this with 3-month history of dysphagia and weight loss, Marian, would you do a laparoscopy?
I would definitely do a laparoscopy. I wouldn't do a EUS, which is what I thought you were going to ask. Yeah, so if they're clinically showing signs that this is, at least a T3, if not more. So sometimes, I see a clinical T2, I get a little bit worried that the cancer is deeper than that if they're having dysphagia.
Yeah, so I would get a CT. I think we need one. You sometimes just see things like infiltration of the tumor into the pancreas or other things. And laparoscopy. And then what would you do?
I would refer him to you. One of the questions sometimes I get asked is someone has an autoimmune disease like the Hashimoto's, like how would you manage that?
Yeah, so I mean, Hashimoto's is relatively mild, so I think typically that would be a totally no-brainer for us to treat. The rule of thumb in general with other autoimmune diseases, because there will be random things that pop up in the chart, you ask the patient if they have a rheumatologist, and if they don't, then it's okay.
Yeah. Yeah, I think we recently shared a patient with UC and well controlled for 20 years on single agent.
That's right, and he's doing well. But that one, we did refer to GI just for blessing, just, because when things come up, to have them. But we've been pushing the envelope more and more, and Hashimoto's is definitely not a red flag. Good question. So unfortunately, the patient had very little response to, I'm guessing, she got dural flot, and had an Ivor-Lewis esophagectomy and, had still positive lymph nodes. So the most common question I get asked is, what do you do in this case? She has grade 2 response. That's good. But let's say if she had no response, what would you do? And what I tell patients and, colleagues is that there's two reservoirs of, cancer, right? You have the primary tumor, but also micrometastatic disease. And actually, we don't know that primary response and micrometastatic disease correlates with 100%. It may not. Basically, the short story is that you decide based on what the patient looks like. If the patient has a lot of weight loss, not feeling well, and you can't medically give them chemo adjuvantly, that's a different story. But right now, the gold standard is to give flat durva still, maybe with a dose reduction, because there's no other therapies that we can give that are better. Irinotecan doesn't work in that case. So often what we do is give flow, durva, so drop the dosi, the third drug. Okay, so I guess we answered all the questions here.
I can answer the next one, the timing consideration. So my rule of thumb is they have to stop losing weight. So typically after a total gastrectomy, you expect them to lose about 10 pounds in that first month. And we see them back every 2 weeks, and we really measure their weight until we see that the weight loss has stabilized. If they are still losing 1 or 2 pounds, but they seem to be getting better or on the right track, I'm okay, you can start. But if they're still on that, can't really, keep food down to maintain their weight, I think that's when they run into a little bit of trouble.
And I think that's what we need to improve on, capturing better, because in the Matterhorn, we had surgical PIs and we made a very clear conscious, effort to include them in the steering committees, et cetera. But I think I see the patients only 4 weeks post-op, right? So this trajectory of improvement, and I think needs to be captured in clinical trials better. But yes, rule of thumb is there's not a rush. You can start you can wait as long as 2 to 3 months. It's better to wait so the patient is used to eating with their new, or reduced equipment, and so that you don't have to interrupt therapy.
Okay, I think the next case is mine. So this is a 58-year-old. He had bloating and weight loss. He does have a prior history of stents ×3, which I was a little bit worried about. And on his EGD, he had erythema of the cardia, also H. pylori positive, and also a signet ring. This is his EGD. You can see all the redness right at the GE junction. You can also see the PET uptake there. Molecular analysis, again, MMR proficient. HER2 IHC was 2+, but FISH was negative. Claudin 1890, and CPS score here is 5. So what would you do, Elena?
Yeah, so I think let's go back for a sec so that we can explain to people what Claudin is. Claudin is a new target that we're developing. It's a cell adhesion molecule, and the fact that they have 90% expression is very good. But right now we don't have a drug that targets. We have a drug, but not in neoadjuvant setting. We have a trial for it. So I think, it's very important to really take into consideration that this is probably a Linnitis case, right? So if you have, very mild uptake, again, I think PET scans sometimes is a trap. People see it and they're like, oh, it's okay. The cancer is not so bad. But if you were to take this patient to the operation, I would bet you my paycheck that it's a T4N1 tumor or N plus cancer. So don't be sort of fooled. In fact, this patient was bloating. I'm worried he has peritoneal carcinomatosis. So he has disease until proven otherwise. And, doing washings is very important. The fact that he's stented is good. That means it's taken care of. And, hopefully it's not a new stent. So all is good. So this patient would probably be perfect for FLOT, really. I mean, unless the weight loss is so dramatic. Sometimes we see, that the weight loss is so bad that they're just not able to tolerate anything. So we do then, I would still do very low dose reduced FLOT, because I think it's very important for the tumor microenvironment to get the third drug. Um, often if they have a nice response, they open up and start eating as early as second cycle.
Yeah. And definitely this is somebody I would do a diagnostic laparoscopy on for the same reasons that you just said. And one of the things I actually look for to capture the melanitis is actually the thickness of the stomach. So I use the bowel graspers. I kind of run the wall of the stomach, and I can just feel that melanitis. Yeah. And you can sometimes even see when it's really bad, you can see the puckering of the tumor on the surface, the serosal surface. And those patients have definitely T4 disease. And what you're trying to rule out with the cytology is whether or not it has spread even further.
Because that's the most devastating thing often. EOSs show T2 because they did an EOS in this patient. And then, again, they'll come in with a positive margin, just devastating. So for the treatment, we would do FLOT Durva. And how would you counsel the patient about prognosis? That's a very good question.
I usually say we have to wait till we get the tumor out, because as you can imagine, the treatment effect to preoperative chemoimmunotherapy matters on prognosis. Patients who have a major pathologic response are going to be the patients who do better. And obviously, we don't know the lymph node status in this patient. And actually, lymph node status is really hard. If you get a PET scan after Durva, lymph nodes always light up. It's actually very annoying as a surgeon, because you're a little bit nervous about some of these lymph nodes. Some of the lymph nodes are not in the local regional area. So sometimes you see a portal cavo lymph node light up and you wonder, hey, do I need to go after the portal cavo lymph node now? But I think this is all in the setting of the immune response being reinvigorated.
Yeah. So that's exactly right. I mean, it's a fine balance about realism, but also, being positive, because the truth is, if this patient has a complete response, or even major pathologic response, the likelihood of survival and cure is just really good. So I think that's the key for these patients, is they do feel empowered, and they love hearing that then your own body's immune system is surveying the cancer and taking care of it while you're recovering from the operation. So and the safety impact, as we mentioned, is quite good. I think, of course, if you're in a center where they can't give FLOT, that's a problem. But otherwise, immune-related adverse events are very rare with this regimen.
So he was started on FLOT, and he had a total gastrectomy, and it was actually a YPT1A. Durva, yeah. T1A N1. It was actually I was very surprised. Yeah, I was very surprised, because I thought that he would have at least a T4 based on the way his stomach looked. So this is the opposite of your case. Would you still give the same adjuvant therapy if you had a good response?
Yes. So the two extremes are complete responders, they don't want chemo, and non-responders on. These people, this guy is easy.
Yeah.
Or woman, I don't know what gender.
Yeah.
But easy, definitely needs it. Especially if, it's a total, right? And so they may not be in great shape for it. So that's okay, because they got a lot. The good news, they got quite a bit of chemoimmunotherapy already. So you could just get away with like fluoropyrimidine, which is the 5-FU with Durva, and they tolerate it well. As you know, our newer trials are now actually giving more immunotherapy and chemotherapy perioperatively. So in patients like this, for example, if they don't want to do more adjuvant, you could just let them be, recover.
We didn't touch upon that, but there are some patients we have done total neoadjuvant therapy on. Those are the patients, let's say his stents were fresh, right? I would be kind of nervous about operating so soon after fresh stents. And those are the patients I would consider giving all the cycles of FLOT up front before taking them to an operation.
Yeah. Okay. Well, I mean, I think we had a great discussion, and maybe we can take some questions. It seems like we have an active online participation.
Okay, so do we have any questions from the audience first? Maybe we should do that.
I guess the question I have, I agree that ECF and MAGIC and now the Matterhorn has long gotten rid of the routine use of radiation therapy. The patients I struggle with are those that have bulky proximal tumors that are primarily gastric, and I'm worried about how much esophagus I'm going to have to resect in a total gastrectomy. And that's a patient that I would consider radiation therapy in. I agree it shouldn't be the standard. That's 20 years ago medicine, but to say never, I wonder if that's too much. I would say, can we say that radiation's appropriate infrequently in patients in whom you're worried about a compromised margin? Particularly, I worry about how much esophagus I'm going to have to take in a patient because that has functional and surgical implications.
Yeah, those cases are really tough. When we present them at tumor board, there's usually a team of thoracic surgeons, and we really talk about, is this the case where they need to go from above? So it depends on how much of the stomach is involved, right? So if it's just the proximal part going up in the esophagus, sometimes you can get away with an esophagectomy and using the rest of the stomach as a conduit. If that's not a case, that's not feasible, we talk about other alternative conduits like colonic interposition to get to what you're saying, a margin negative resection. We don't really consider radiation in that sense because for us, the morbidity from radiation, the leak rate that you're going to get is just as morbid as a colonic interposition, right? So those are the things that we are considering. There are some instances where we have a really difficult conversation about local control, like if there's lymph nodes involved and we have a fear that we're not going to get a complete local control. Sometimes in those cases, we would consider radiation.
So I think it's a very good practical question. And the way I would approach it is, and what we do in those cases, we do more protracted form of chemoimmunotherapy. And then if there's still a suboptimal response where you don't think you're going to get an R0 resection, 3 large phase 3 studies demonstrate that adding radiation is not going to improve survival. So you could operate on them, but you should realize that they're going to die with metastatic disease very soon. So the way that we approach this then is, yes, I agree, some form of local therapy is needed, but doing chemo-RT and then surgery is just too much, and they're not going to be cured. So then we do, in those cases sometimes, or if it's an elderly patient, medically, difficult operation, you do chemo-RT. So we start with FLOT Durva often, then we downgrade to FOLFOX Durva or flow Durva. And then there's maybe 4 or 6 months into the whole thing, there's a decision point. And, I think being creative and having and I know not every hospital can do this, you can get them through surgery. And if you can operate, great. We even operate on oligometastatic cases like that if there's real great response. But I would argue that, and, I have good radiation oncology friends, et cetera, but it's really, it's a detour. Radiation is a detour here. It's not a cure.
Yeah, we try very hard to get them to surgery creatively.
Thank you. Eduardo Guzman from Monterrey, Mexico. Another surgery question. So for diffuse gastric cancers, we traditionally have done total gastrectomies. However, we're getting better responses now. And so we're starting to do subtotals or maybe partial gastrectomies, even if they're diffuse, as long as we can get a negative margin and it's wide enough. And how often do you feel at MSKCC, do you feel comfortable, recommending our patients subtotal gastrectomies? And what guidelines do you use to determine whether they had an appropriate operation?
Yeah, so that's also a good question. So we are comfortable. doing less than total for diffuse gastric cancer is a short answer. We do routinely, me and my two other partners, we do routinely check the proximal margin, right? And really the question is, how far do we chase that proximal margin? And I actually have a very long conversation with these patients beforehand. And I tell them I will chase one margin, because usually one margin is safe to chase, meaning if you did a subtotal, you're going to get a total. But I don't chase the margin further than that, because biology shows that if you have 3 positive lymph nodes and you're chasing that margin, it makes no difference. R1 resection versus R0 resection has no difference in outcome once you're looking at 3 positive lymph nodes, which typically these patients will be.
Zahra Shafai, New York. I was wondering about the second patient and you did cytology. So if that cytology is positive, would you do HIPEC?
That's a very good question. So at our institution, we don't do HIPEC, but we are enrolling in the stopgap trial. And Maggie is presenting some of the findings, I think, tomorrow. So that's a trial with intraperitoneal chemotherapy. It's off of the Asian trials, Dragon trial, which showed IP paclitaxel plus systemic had some combination effect in the IP arm. So we don't do HIPEC, but we are enrolling patients on the stopgap trial. Anyone else in the room, or we can? Well, you guys. Oh,
thank you. Hi, good night. Thank you for your wonderful talk. I'm Victor Dominguez from Riverside. I'm a research fellow. And in fact, during the last 2 months, I have been working with the NCDB, analyzing the treatment patterns for esophageal and G-junction cancer. I am actually too surprised to see how rare it is to treat patients with perioperative chemotherapy in the esophageal and G-junction scenario. Do you think this is the end of the controversy for the superiority of neoadjuvant chemoradiotherapy and for the diffuse type gastric cancer controversy? Because what I see from your forest plot is the same criticism that some opponents have against the role of durvalumab and FLOT for diffuse gastric cancer, that the confidence intervals cross 1. So basically, there are some people saying that the benefit is only applying for adenocarcinoma and not otherwise specified, or intestinal type adenocarcinoma of the stomach, no? But for diffuse...
Sure. It's a common question. We actually, it's well addressed in the paper, but essentially, if you looked at the forest plots, the diffuse gastric cancer is a subset, but non-otherwise specified is the larger subset, and then intestinal is the third, right? So NOS actually includes a lot of diffuse gastric cancers because WHO criteria is only assessed. So this was basically based on local assessment. In other words, we didn't have a central pathologist reviewing everything. So if your center indicated diffuse gastric cancer, we wrote it down because we knew it was but nobody confirmed it. But more importantly, many patients were NOS because nobody cares at their center whether or not they're diffuse or intestinal. So I think it's, like everything else, at these conferences we need something to argue, right? So us in academic centers love to argue about these things, but in reality, if you look at the reality, it's just who is the most vocal person at the DMT. So you're right. If radiation, oncologist is super vocal, a lot of people are still getting chemo-RT, right? Maybe because the oncologist is less present, or the surgeon doesn't really, drive the bus and lets them do whatever. So I think the culture is shifting. I see it. I think it's slow because it is an orphan disease. And I agree with you, esophageal and G-junction tumors are probably the slowest to shift. And that's why, we do these meetings, and also hopefully the patients will vote with their feet, right? Because the outcome matters so much where you go get your care. If it's in a tertiary cancer, or if it doesn't have to be tertiary cancer. It has to be with a doctor who reads papers, right?
Yeah. I mean, my last patient was signet ring, and I honestly don't want to know if he would have had the same great response without Durva, right? Because why? He tolerated the therapy well, had no adverse events from it, and I would give him the exact same therapy again. Okay. The first question is it always necessary to perform molecular profiling on GE junction cancers at diagnosis, even if it's stage 3? Yes.
Because they're all going to recur, so you need to know.
Yeah.
Well, hopefully they won't. But it's, MSI you need to know, right? Because again, it'll give you risk-benefit ratio, as I said in my talk. If it's a little old lady, like 85-year-old, what are you really trying? She's going to be fine. Just you could potentially resect her and she'll be fine. And so on. HER2, PD-L1, I mean, we have so many options for therapeutic space. So it's important to know. And it's easy. I mean, you can send it out or have you done locally. 89-year-old.
Yeah. GE junction localized in an 89-year-old treated with concurrent chemo-RT. So must have been treated at the community. Post-treatment PET and ctDNA was negative, so that's good. EGD 5 weeks showed similar GE junction mass with no treatment effect. Next step was systemic therapy, NGS with HER2 negative, CPS greater than 10, no targetable mutations. 89-year-old is really tough at the GE junction site.
The most 89-year-olds tell you what they want, though.
That's true. They usually vote with their feet because they stop showing up to my clinic, and usually I take it as a sign that they know what they want.
Right. And the fact that she got a chemo-RT was probably because she didn't want surgery. So, I mean, it's tough. We do things cryo and other, but it's palliative. So probably a feeding tube and then some sort of palliative therapy. Sad.
Treatment for large 15-inch times 5 in gastric growth non-Hodgkin's with its own blood supply not responding to chemo. Yeah.
Yeah. So is there a rationale for using Duraflot for more cycles perioperatively since many patients never reach adjuvant therapy? Yeah, that's exactly all of our studies now. So we have a HER2 positive study, which is FLOT, Pember, Traz, and we're seeing high rate of pathologic complete response. And there, in that study, we're doing 6 cycles. FLOT for all 8 cycles is tough, but 6 cycles is very much doable. And the data is looking pretty good. And the same thing we're doing for HER2 negative with dual immune checkpoint blockade with FLOT also. So that's the wave of the future. Try to give a lot of if the surgeons, agree, and you give more perioperative and then just leave them alone after.
And what about patients who are Claudin 18 positive? Does Durva help them?
Claudin 18.2 is one of those biomarkers that occurs at low. It's not a driver of the cancer, so it's one of those things are in there, but we don't know exactly if it even predicts response, for example, to ADCs. So yes, and the short answer is yes. But and the fact is, if you've ever seen a patient getting anti-Claudin therapy, their degree of nausea is astronomical. So if the primary tumor is in place, Claudin 18.2 therapy will be very challenging. So if anything, we're looking at some studies where you would do FLOT Durva perioperative, and then after you do the surgery, because the primary is no longer there, most of the stomach is gone, so their nausea, because the nausea comes from effect on the normal epithelium as well, the tight junction. So then adjuvantly, they tolerate it much better. Probably a little more detail than you guys were hoping for, but okay, I think that's it.
There's
more questions. Okay, your turn.
In what situations would you use perioperative FLOT over neoadjuvant chemo-RT? What about vice versa? I think in all situations we would use perioperative FLOT. The only
Durva.
Durva, yeah, and only
I think chemo RT is still okay if you're going to say this patient is not
Correct,
I don't want to
yeah.
operate on them, like that 89-year-old person.
Yeah.
Right?
And that's usually a tumor board discussion that we have because about the morbidity of the surgery.
The way that I tell my patients, there's, two types of therapy, local or systemic. You don't need two things of systemic therapy. You just need one local therapy, one systemic, right? So, and surgery is the gold standard for local therapy, not radiation, because most patients won't be cured.
Yeah, and the next question we get a lot, is there a rationale for using adjuvant deflot in a patient who receives a past CR after neoadjuvant deflot in surgery?
Yes.
Yeah.
Until we have more data to downstage on. These are the people who are likely will be cured. So you can go easy on them if they're having side effects, but if they're tolerating the therapy well, I would go for it.
And what is your experience using neoadjuvant Durvalumab and surgical complications? They're essentially the same as the data shows. Yes, the planes are stickier. Yes, the lymph nodes are scarier, but the complications themselves, I have not seen more leaks, which is the one that we care the most about, or other.
But delays to getting them to surgery.
I've had one delay to getting to surgery. Patient actually developed ATN nephritis at the last cycle, and his creatinine quadrupled, which was a little bit scary. So we did steroids, and then we waited. That was the only one. That was the only delay that I can remember in my practice.
To Matterhorn, we recruited 50 patients, but that was probably before you were there. And then since then, we've been using, so one is not bad.
Yeah, but the colitis is usually very self-limited. The endocrinopathies are well managed with Synthroid, and our endocrinologists are great at managing that. And then the skin rashes, usually there's topicals that they use, and also very well managed.
Do you use ctDNA in deciding, that's a great question, whether or not to continue adjuvant therapy? What is your protocol for postoperative follow-up, short-term, long-term? I worry about ctDNA because we see, even with newer platforms like Signatera and so forth, we see about 15% of patients that may recur just even if ctDNA negative. Because remember, these tests are designed to pick up mutations, and our tumors, even though they have p53 mutation, most of them are amplifications, right? And those they don't detect as well. So I don't use ctDNA outside of a clinical trial. I know our surgeons love to check ctDNA, and then they send them to me with ctDNA positive after FLOT. A lot of times we just monitor. I wouldn't continue protracted course of treatment just because it could be CHIP, it could be other things, it could clear on its own. So that's why I think only in a clinical trial do we do it. And then what do we do postoperatively? I see them 4 weeks post-op. You see them 1 or 2 weeks.
I see them every 2 weeks until they go to the medical oncologist.
I see them 4 weeks post-op, then just pep talk and plan, and then 2 weeks later they were already ready to start. So at 6 weeks, most people can start, maybe at 8 or 9 at the latest, and then they continue the treatment. We usually see them so that the Durva is for the whole year, so it's 10 cycles, and then so we don't scan in that period, and then I usually scan them 3 months after the last Durva. And then they get visits with us every 3 months, scans twice a year for the first 2 years, and then once a year for 3 more years. So, and then we graduate them. They don't want to leave, but
yeah. And I see them if they get a total, I see them for their nutrition labs and make sure they're B12 and iron and chromium and all that things, or xenium and all of those things are fine.
What's that?
Yeah, there's heavy metals that you test for too. Yeah.
Go to your internist for that.
Yeah.
All right. Thank you.
Thank you.
We're on time. Okay.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca.